the orbit. So the dissection order is going to be as follows. First, you're going to study the bones of the orbit. I would really recommend, even if you don't love those videos, the ones that I did with Complete Anatomy on YouTube are actually really good. They cover all the bones of the orbit and much more. Okay? We're going to dissect the right orbit from a superior approach and the left one from anterior. We're going to study cranial nerves 3, 4, V1, and 6. Okay? We're going to follow them through the superior orbital fissure into the orbit, and the extraocular muscles will then be identified. Really try hard to identify all those muscles. Okay? They are small. The orbit is challenging, but is also very rewarding. It has a lot of really cool stuff in it. Okay? Rest here, I've already mentioned. Left orbit is going to be done from the anterior aspect. You will see that some of your donors will have implanted lenses. That's really interesting. You can cut the lens out, or if you open up the eyeball from anteriorly carefully, then you can probably extract the lens. It's really pretty easy. And then you're going to study the attachments of your extraocular muscles. Here are your learning objectives. Study this slide at your own, please. Surface anatomy of the eye. In the eye, there are a couple things that most of us already know, but let's just repeat that. We have here the pupil, the iris that gives your eye its color, of course, and the bulbar conjunctiva. Okay. In addition to that, you actually have this little recess here. This is the inferior conjunctival fornix. There's going to be a superior one as well, not really in this image. There's the lacrimal caruncle within a lacrimal lake. Okay. There's also a semicircular skin over here, or half moon shaped. It's what's called the plica semilunaris. Okay. Down here you also have then, this is the inferior lacrimal papilla and punctum. That is part of the drainage system for tears. When the eyelid closes, it actually closes from superolaterally to infromedially, so it'll wipe a thin layer of tears across your eyeball from superolateral to infromedial, and with every blink of an eye you have just a tiny bit of tear fluid that drains into your nasolacrimal duct, which is going to be medially. The conjunctiva. The conjunctiva is basically the innermost layer of the eyelids and the outermost layer of your eyeball. Yeah, so directly on the eyeball and on the eyelids. On the eyelids, as the eyelids are called palpebra, it is called palpebral conjunctiva. And directly on the eyeball itself, it's called either bulbar or ocular conjunctiva. That just lines the outermost part of your eyeballs. Between the two is the so-called conjunctival sac. You can also get inflammation of the conjunctiva that is called pink eye, especially prevalent in kids with dirty hands. Let me show you a side view or a lateral view here. This is the outline of the conjunctival sac. You can see the conjunctiva are continuous with each other, so people that wear contact lenses, there is actually no way of losing the contact lens behind your eyeball. If so, seek medical attention immediately, because that is anatomically actually impossible. Next, glands of the eyelid. Okay, you actually have these tarsal glands. Okay, they are sebaceous glands. Yeah, they're also called meibomian glands. They will help secrete a substance called sebum. Yeah, that prevents the eyes from drying out, but it also helps prevent the eyelids from sticking together while you blink. Okay, so they also help when your eyes are closed to form a barrier that is pretty much airtight. Okay. And if you have dysfunction of your tarsal glands, it can lead to chalasia, which is also called dry eye syndrome. It can also cause cysts. Right there is the outline of your meibomian glands. The lacrimal apparatus. In brief, your lacrimal glands will sit in the superolateral corner of your eye. Fluid is secreted out of the lacrimal glands onto the eyeball. While you blink, it gets pushed medially and inferiorly and drains through the nasolacrimal duct into the inferior nasal meatus. Here are the excretory ducts of your lacrimal gland. The plica semilunaris of the lacrimal lake, the little skin here. The lacrimal caruncle, it's like a little island within the lacrimal lake. You have the superior lacrimal papilla and punctum, which is the opening, and the inferior lacrimal papilla and punctum, which will then drain into the lacrimal canaliculi, little channels, into the lacrimal sac. Down it goes through the nasolacrimal duct, through the opening of the nasolacrimal duct into the inferior nasal meatus, which is deep behind the inferior nasal concha. Boom. Innervation of the lacrimal gland, hashtag really important, okay? Your presynaptic parasympathetic fibers are going to be coming from cranial nerve number 7 via the greater petrosal nerve. Yeah, that will carry presynaptic parasympathetic fibers. The postsynaptic parasympathetic fibers are going to be conveyed by branches of cranial nerve number 5. Yeah, because remember, your greater petrosal nerve merges with a deep petrosal nerve to form the nerve of the pterygoid canal. And then the parasympathetic fibers that are presynaptic synapse in the pterygopalatine ganglion and ascend via a convoluted pathway, hop onto V2 branches, and then ultimately onto the lacrimal nerve to go to the lacrimal gland. And that is where tears are then produced. Bones of the orbit. The frontal bone makes up the entire roof of the orbit. Medially here, the little yellow bone, which is really, really thin, is made up by the ethmoid bone. The lacrimal bone also contributes a little bit to the medial wall. Laterally, and the roof near the apex is made up of the sphenoid bone in a kind of orangey color. The lateral part and the floor is made by the very strong zygomatic bone, and another contribution to the medial wall and the floor is by the maxilla. Openings or foramina in the orbit. Optic nerve and ophthalmic artery will pass through the optic canal. Cranial nerve 3, the oculomotor nerve, V1 ophthalmic division, cranial nerve 4 and 6 will pass through the superior orbital fissure. Also, the superior ophthalmic vein passes through there. The infraorbital nerve, the infraorbital artery and vein, and the inferior ophthalmic vein will pass through this opening, which is the inferior orbital fissure. Clinical correlation, blowout fracture. With enough force applied directly onto the eyeball, you can rupture some of the associated walls. Yeah? If it's the inferior wall, then it would actually go into the maxillary sinus down here. And that is called a blowout fracture. Yeah, commonly it occurs with the involvement of the medial wall, which would mean that you then also take into account, or you also involve the sphenoidal and ethmoidal sinuses. Yeah, if it's the inferior wall, like here, and actually also on the, well, you're gonna have to go back in your PowerPoint, look at the coronal section in the scan down here. You can see it actually involves the maxillary sinus. It can result in exophthalmos, displacement of maxillary teeth, and fracture of the nasal bones, which results in hemorrhage, and because you created a connection between the orbit and the maxillary sinus or other sinuses that are involved, of course it can lead to infection. Layers of the eyeball, sclera, and cornea are part of the fibrous outer layer. The posterior 5/6 of the globe are relatively avascular, made up of sclera and cornea. Then you have the vascular layer, yeah, is the middle layer. You can see it right here. It is made up of the choroid, the ciliary body, and the iris. Then you have the inner layer, which has the visual and non-visual part of the retina. Yeah, so the visual part of the retina transitions into a non-visual part of the retina at the serrated edge called the ora serrata. Okay, and back here you have the optic disc, which also, well, that is exactly where the optic nerve enters. So that's actually not where you have any photoreceptors. That's your blind spot. Okay. So you have the fibrous outer layer, the vascular inner layer, and the most inner layer, the retina. I just misspoke here. This is actually the middle layer that's vascular. Cornea. The cornea itself is actually avascular, and it is transparent so that we can actually see, right? It does, however, receive its nourishment from capillary beds at its periphery, from aqueous humor, which is deep to it, and lacrimal fluid on the outside. It covers your iris and your pupil and the anterior chamber, which is going to be right here. Yeah, the cornea is actually the major refractive medium of the eye. yeah, more refractive than the lens, okay? It also filters out UV light. It is really sensitive to touch via the ophthalmic division of the trigeminal nerve or the ophthalmic nerve, yeah? That provides the afferent limb for the blink reflex. Blink reflex, afferent via V1, efferent via the zygomatic branch of the facial nerve, okay? So if you touch someone's cornea and they blink, you know that the afferent one was from the trigeminal nerve and the efferent limb was from the facial nerve. However, absence of the blink reflex does not necessarily mean that either one or the other is damaged. You can either sense the touch via the cotton swab in this case, but with a damaged facial nerve you will have no reflex, or you will have damage to the ophthalmic division of the trigeminal nerve, so you can't feel something in your eye, although the facial nerve is totally okay. So absent blink reflex means either or are broken. Well, in the worst case, both will be broken, but how do you find out which limb it is? About the vascular layer, the choroid, okay? The largest part of the vascular layer is the choroid, right? All the arteries feeding into it are branches of the so-called ophthalmic artery, all right? It has a darkish reddish brown membrane that's between the sclera and the retina. It lines the vast majority of the sclera. The deepest layer, which we can see in this flash photography down here, is called the choriocapillaris. It nourishes the most outer cones and rods, which is within your retina. And as I just said, this red eye reflection, which we all dread in flash photography, is caused by the choriocapillaris. More about the vascular layer. We have the ciliary body and the ciliary process. The ciliary body is a ring-like structure that is muscular and vascular. The ciliary processes are the ones that actually secrete a substance called aqueous humor, and that will fill both the anterior and the posterior chambers. The anterior chamber is the space between your cornea and your iris and pupil. The posterior chamber will be the space between the iris or pupil and the lens and the ciliary body. The flow of aqueous humor is as shown here. It is produced in the posterior chamber by the ciliary processes of the ciliary body, back here. It will then drain into the scleral venous sinus, which is also called the canal of Schlemm. If the outflow here is obstructed or there's too much aqueous humor produced, it leads to too high pressure, which then can cause the condition glaucoma. Here one more time, the flow of the aqueous humor produced by your ciliary body flows around here, in between the zonular fibers that are suspending your lens, and then gets reabsorbed by the canal of Schlemm. It's also called the scleral icterus sinus, I believe. Just call it canal of Schlemm to be safe. Ciliary muscle and the lens. This is important. The ciliary muscle is going to be responsible for determining the shape of the lens, which you need for near vision or far vision, right? So, under relaxation, the zonular fibers that are the ones that are suspending the lens, right, are going to lead to a flattened lens. Yeah, that is good for far or distant vision. Okay, so in the absence of nerve stimulation, which comes from motor fibers from cranial nerve number 3, the oculomotor nerve, your ciliary muscles are going to be relaxed and the fibers will be under tension. Lens stretched thin for distant vision. Now, anybody who works in an environment where you have to often focus on reading a book or a screen or so will know that a tension headache that this can cause is due to, or if you don't know it, it'll make sense that it's due to having this parasympathetic innervation of your ciliary muscle. That actually contracts the muscle, makes the ring a little bit smaller, the fibers relax, the lens becomes more like a marble, more spherical, and that will then refract light for near vision. Okay. Here, in normal vision, you can see here's a close or distant object. The change of the shape of the lens is supposed to be able to help you create a perfectly focused image on the retina. On the other hand, in myopia, a distant object, the image will be formed in front of the retina. Vascular layer, the iris. The iris determines the color of your eyes and more. Here's your dilator pupillae that makes the pupil big, that's innervated by sympathetics, and the sphincter pupillae is this ring, that has circular fibers, which is innervated by parasympathetics. Dilator pupillae, sympathetics that have most likely synapse in the superior cervical ganglion, and the sphincter pupillae comes via the ciliary ganglion from the oculomotor nerve that makes a small pupil. So in dim light, like at nighttime, you'd actually have your postsynaptic sympathetic nerve fibers that stimulate these radial muscles to pull the pupil open to let more light in. In bright light, the parasympathetic stimulation from the oculomotor nerve, whose presynaptic parasympathetic fibers will synapse in the ciliary ganglion, and the postsynaptic fibers then go to the sphincter pupillae that leads to the pupil being closed down and made smaller. Pupillary light reflex. So the afferent limb is via the optic nerve. The efferent limb is via the oculomotor nerve. So the course is as follows. Sunlight goes through the eye, via the retina, via the optic nerve, into the brain, to the Edinger-Westphal nucleus, and then via there to the ciliary ganglion, synapse occurs, goes to the sphincter pupillae, and the pupil gets smaller. Okay, that was pretty fast. Let's do this one more time. I actually nearly forgot to tell you about the pretectal nucleus. So, one more time. Here is your efferent limb, sunlight. Sunlight through eyeball via retinal hypothalamic tract. Over here, pretectal nucleus, Edinger-Westphal nucleus, presynaptic fiber, ciliary ganglion, synapse, sphincter pupillae, pupil small. Because also, as you can see here, and it's clickable if the link still works, because we have partial chiastonuria, that means partial crossing over of the optic nerve and the optic chiasm, an intact system of a pupillary reflex will occur in both eyes, even if only one is illuminated. So that's called consensual light reflex. If I shine a light into the right eye, the pupil should contract, but the consensual part is because the partial chiastonuria should actually also have the left eye contract. So it's kind of also a check for instance, oculomotor nerve damage. If you shine a light into one eye, the other eye or the other pupil should also contract consensually. So the orbits are basically bony cavities of the facial skeleton that resemble a hollow quadrangular pyramid each, with their bases directed anterolaterally and their apices posteromedially. The medial wall of the two orbits are separated by the ethmoidal sinuses, and the upper parts of the nasal cavity are parallel, whereas the lateral walls are nearly at right angles, so nearly 90 degrees, like this and like this. Consequently, the axes of the orbits diverge at approximately 45 degrees. The optical axes, the axes of gaze, the direction or line of sight for the two eyeballs are parallel. However, we're trying to look in the same direction with both eyeballs. The orbits contain and protect the eyeballs, or globes of the eyes, and of course, any accessory visual structures. Movements of the eyeball. The lateral and medial recti will cross only the vertical axes, and consequently cause only a abduction and a deduction, respectively. These muscles can be tested simply by asking a patient to abduct or deduct. Inability to do so indicates that the muscles and/or their innervation have been compromised. In contrast, the superior and inferior rectus muscles cross all three axes, the vertical, the horizontal, and the anteroposterior axes of the globe. Therefore, concentric contraction of each of these muscles results in 3 movements: abduction or adduction, elevation or depression, and intorsion or extorsion. These muscles must be tested with a sequence of 2 movements. Gaze can either be elevated or depressed, both by an oblique and a rectus muscle. If abduction or adduction occurs first, one muscle of the pair becomes incapable of causing elevation or depression of the pupil. This rationale for abducting or adducting first, that either the oblique or rectus muscle of the pair will no longer cross the horizontal axis and will be then unable to effect the muscle's movement. Inability to elevate or depress the gaze from the abducted or adducted position shows which muscle, the oblique or rectus, and or its innervation, has been compromised. As you are probably realizing, the movements of the eyeball within the orbit are quite challenging. Hence, there is an extra video solely with a purpose on explaining the extraocular muscle actions. This should be loaded on your LMS or Learning Management System. Extraocular muscles rarely act independently. Synergistic and antagonistic activity occurs between muscles most of the time. Muscles that are synergistic for one action may be antagonistic for another. This is just a summary on this slide. The levator palpebrae superioris, broadens into a wide bilaminar aponeurosis as it approaches its distal attachments. The superficial lamina attaches to the skin of the superior eyelid and the deep lamina to the superior tarsus. The recti and oblique muscles. There are 4 rectus muscles or recti. They arise from a fibrous cuff back here called the fibrous ring or annulus of Zinn that surrounds the optic canal and part of the superior orbital fissure. Structures that enter the orbit through this canal and the adjacent part of the fissure lie at first in the cone of the recti. The lateral and medial recti lie in the same horizontal plane, lateral and medial, in the same horizontal plane, and the superior and inferior recti lie in the same vertical plane. Neither the superior rectus nor the inferior rectus pulls directly parallel to the long axis of the eyeball, which would be the neutral axis of gaze. As a result, from the primary position, both recti tend to move the pupil medially, so they will adduct it. So if I pull on the superior rectus, it'll elevate, but also adduct the eyeball. This medial pull of the superior and inferior recti is normally balanced by a similar tendency of the oblique muscles to move the pupil laterally, which is abduction. From the primary position, the inferior oblique directs the pupil laterally and superiorly. Therefore, when the superior rectus and inferior oblique work synergistically, pure elevation of the eyeball occurs. Similarly, the superior oblique directs the pull inferiorly and laterally. Therefore, when the superior oblique works synergistically with the inferior rectus, pure depression results. When the pupil is already in the adducted position, the oblique muscles are responsible for elevation and depression. Respectively, that would be the inferior oblique for elevation and the superior oblique for depression, moving the gaze up or down the page. That's why your obliques are really important to work properly if you're reading text in a book. The mnemonic device we can use for the innervation of the extraocular muscles is LR6, lateral rectus, cranial nerve 6, SO4, superior oblique 4, and everything else 3, oculomotor nerve. Imagine the line of pull between the eyeball and the muscles. The resulting movement depends on the starting position. Okay, so the movement directions are going to be indicated by large arrows, and that means between the large arrows it requires synergistic actions by adjacent muscles. Direct elevation of the eyeball requires, for instance, synergistic actions of the inferior oblique and superior rectus. Both eyes need to be coordinated with each other. Muscles that are paired are called yoke muscles. To look up and out, as here, we need the inferior oblique and the superior rectus. To look straight off to the side, the eye that is abducting will be activated by the lateral rectus, the eye on the contralateral side by the medial rectus. This is the primary position. To look down and out, we activate the superior oblique in this eye and the inferior rectus in this eye. Remember, you have to align the line of pull with the muscles you want to test the axis around which movement will occur. To create, for instance, elevation only, we have to abduct the eyeball so that the direction of gaze is exactly the same direction as the direction of pull of the superior rectus. The abducted eyeball, when we activate the superior rectus, you have pure elevation. If we activate the inferior rectus and the abducted eyeball, you have pure depression. Over here, if I activate the superior oblique in the adducted eyeball, it leads to pure depression. If I activate the inferior oblique in the adducted eyeball, it leads to pure elevation.
When the eye is abducted 23 degrees, the superior and inferior recti are aligned with the axis of the eye. They therefore act purely to elevate and depress the abducted eye. The superior oblique acts to intort, and the inferior oblique acts to extort the abducted eye. When the eye is adducted, the inferior oblique and superior oblique become the main elevators and depressors. The superior rectus now primarily intorts and inferior rectus primarily extorts. The superior rectus now primarily intorts and inferior rectus primarily extorts.
For instance, to test an isolated muscle, the pupil has to be averted from the primary position first, either abducted or adducted. We align the line of pull. Only the actions of the medial, innervated by cranial nerve 3, and lateral rectus, cranial nerve 6, are tested, starting from the primary position. If I'm looking straight forward, activate the lateral rectus, I will abduct the eyeball. It is only the lateral rectus that is tested. If I adduct it, so look towards my nose, I test the medial rectus. When the eye is adducted, the oblique muscles are solely responsible for elevation, inferior oblique, and depression, superior oblique. When the eyeball is abducted, the muscles causing elevation and depression are going to be the superior rectus and inferior rectus. Nerves of the orbit. I've actually color-coded the nerves and muscles to correspond with each other. The lateral rectus is innervated by the abducens nerve, cranial nerve number 6. The medial rectus and all other muscles except for the superior oblique are innervated by branches of the oculomotor nerve. The superior rectus, the superior oblique, is innervated by cranial nerve number 4, which is the trochlear nerve. It's called the trochlear nerve because the superior oblique runs through a little pulley here that redirects the pull direction of the superior oblique. The pulley is called the trochlea. You will encounter several more of these nerves in lab. you'll have your branches of the oculomotor nerve, which actually splits into superior and inferior divisions, but it's all oculomotor nerve. You have your trochlear nerve, cranial nerve number 4, and your abducens nerve going into the lateral rectus. You have the lacrimal nerve from cranial nerve number V1 going to the lacrimal gland that will supply postsynaptic parasympathetic fibers to the lacrimal gland. The frontal nerve is purely sensory. It is part of V1, which will then later on split into the more medial supratrochlear nerve and more lateral supraorbital nerve. Please note that the LPS, or levator palpebrae superioris, also is innervated, just like the superior rectus and most of the other muscles of the orbit, by the oculomotor nerve. Remember that the trigeminal nerve is deemed the great sensory nerve. You have your 3 divisions. V1, the ophthalmic division, will pass through the supraorbital fissure. V2, the maxillary division, will pass through the foramen rotundum. And V3 will pass through the foramen ovale. V1 up here will actually trifurcate into 3 nerves: your frontal nerve, your nasociliary nerve, and your lacrimal nerve. Remember the useful mnemonic LR6, SO4, 3. Here's your ciliary ganglion, receiving fibers from the oculomotor nerve. From here on, your postsynaptic parasympathetic fibers will go into the eyeball to go, for instance, to the sphincter pupillae, and the ciliary muscle to change the shape of the lens. The optic nerve, cranial nerve number 2, is purely sensory, and it conveys, of course, optic stimuli. It is invested with the meninges of the cranium and also with the extension of the subarachnoid space. Yes, there's a little bit of CSF around it. Within the optic nerve, you will find a very important artery and vein, which is going to be the central artery and vein of the retina. They will cross the subarachnoid space and run with the distal part of the optic nerve. Here's the central artery and vein of the retina. Oculomotor nerve passes through the superior orbital fissure and then divides into superior and inferior divisions. Okay? The inferior division also supplies presynaptic parasympathetic fibers to the ciliary ganglion, which is destined for the constrictor pupillae and the ciliary muscles. Clinical correlation, oculomotor nerve palsy. In oculomotor nerve palsy, you have a droopy superior eyelid, which is called ptosis. Your pupil is going to be fully dilated and non-reactive. The lack of parasympathetic innervation causes this because you have unopposed sympathetics, and the pupil will be abducted because you have the lateral rectus that pulls laterally, and it'll be depressed as well because you have unopposed action of the superior oblique. So your gaze will be out and down, or down and out. Trochlear nerve and abducent nerve. 1, 2. Both pass through the superior orbital fissure. The abducens nerve passes through the common tendinous ring, but the trochlear nerve does not pass through it, it passes above it. The trochlear nerve runs across the surface of the LPS due to its long peripheral course around the midbrain. Cranial nerve number 4 is particularly susceptible to head trauma. The abducent nerve, on the other hand, runs through the superior orbital fissure and common tendinous ring and innervates only the lateral rectus. When the abducent nerve is paralyzed, the individual cannot abduct the pupil on the affected side. The pupil is fully abducted by the unopposed pull of the medial rectus. Clinical correlation here, abducens nerve palsy. If cranial nerve number 6 is paralyzed, the lateral rectus will not work. In this image, this guy was asked to look at the pen or whatever it is. It's like, hey, look at the pen. And you can see that the left eye just staring forwards because the lateral rectus does not work. Then the right eye, the medial rectus, works, so he is gazing at the pen. However, without the lateral rectus and the abducens nerve, this does not work. Okay. Also, because it arises at the bottom of the brain, it is often the first nerve that is compressed when there is any rise in intracranial pressure. This here is a possum, and it looks like it's kind of got a bilateral abducens nerve palsy. I think that might actually just be the way that possums look. This ciliary ganglion. The ciliary ganglion that we have here just has a small group of postsynaptic parasympathetic nerve cell bodies. It's pretty small. It's also hard to find in lab, but it's possible. They're going to be associated with cranial nerve V1 fibers that are received from V1, the sensory fibers. They will actually just pass through the ganglion because the only thing that synapses here is 2 presynaptic parasympathetic fibers from cranial nerve number 3. And 3 postsynaptic sympathetic fibers will run right through from the internal carotid plexus and go to intraocular blood vessels, for instance. And sympathetics also go to the dilator pupillae. Okay, so sensory fibers traverse the ganglion. Sympathetic fibers bypass or traverse the ganglion. And parasympathetic fibers synapse in the ganglion. Remember about the sympathetic innervation of the head. Presynaptic fibers destined for the head originate in the intermediolateral cell column in between T1 and T3. And they go up or ascend. They synapse in the superior cervical ganglion. Then they will leave via cephalic arterial rami, and then from a periarterial plexus around the carotids here, they will go up into the head and follow the artery to their target organs. Horner syndrome, oldie but goldie. The cause is interruption of a cervical sympathetic trunk. Absence of sympathetically stimulated functions of the ipsilateral side of the head are then the result. Symptoms are miosis, constriction of the pupil because you don't have any dilation from the sympathetics. You have unopposed parasympathetic stimulation. Drooping of the superior eyelid, you can see here, ptosis. Redness and increased temperature of the skin, vasodilation. And you can't sweat because you don't have any sympathetics left. That would be anhydrosis. Vasculature of the orbit. In brief, mainly from the ophthalmic artery. Also very important, the central artery of the retina will run within the dural sheath of the optic nerve, as I've already said, and you have a very rich vasculature of the orbit. The ophthalmic artery is actually a branch of the internal carotid artery. The infraorbital artery from the external carotid artery also contributes to blood structures, or to blood supply to structures related of the floor of the orbit. You also have 6 short posterior ciliary arteries that can probably vary a little bit that supply blood directly to the choroid. Remember, that's the vascular layer of the orbit. You often have 2 long posterior ciliary arteries that pass between the sclera and the choroid, and anastomose with the anterior ciliary arteries. Here you can see the macula of the retina, the point of highest acuity, the optic disc, which is where the optic nerve enters. There ain't no rods and cones you can't see there. That is also the blind spot. Veins of the orbit, superior ophthalmic vein and inferior ophthalmic vein. You also have the central vein of the retina that will be running right in the optic nerve then, and so-called vorticose veins that are going to the posterior aspect of the eyeball. That's all I had for now. Just hit play on the slideshow, on the PowerPoint, and you should be able to watch this as a movie. Thank you very much.